let's understand how do we manage a fracture, how do we treat it, like from temporary stabilization with splinting to your definitive treatment. So for that, you need to understand a few terms, right? These terms will be used quite a lot. So I want you to familiarize yourself with these terms. What are these terms? Displacement, reduction, traction, and fixation. Now, to appreciate what these terms are, let's first take an example of a fracture. I will give you a supracondylar humerus fracture, for which I will have to draw the lateral view of the elbow. Say this is your humerus. Okay, and this is the bone that articulates with the humerus, that is your ulna. And there is another bone here, which is your radius. Now tell me which muscle comes and attaches to the tip of the olecranon, right? All of you know this. Which muscle is that? Quadriceps, hamstring, calf muscles, triceps. Yes, triceps, right. So let's talk about supracondylar humerus fracture, which means that the fracture occurs just above the condyles of the humerus, right? So these are the condyles of the humerus. The fracture occurs just above the condyles of the humerus here. Okay, so if I have to draw the fracture, it will be something like this. This is the supracondylar humerus fracture. Now, in supracondylar humerus fracture, what you need to understand is, following the fracture, the triceps muscle pulls the fragment away, right? So when this fracture moves away from normal anatomy, this is what we call as displacement of the fracture. This is displacement of the fracture. And what causes the displacement of the fracture? The pull of the muscle. So this is a posteriorly displaced supracondylar humerus fracture, or an extension type of supracondylar humerus fracture, because it's going posteriorly, and this is a anteriorly displaced supracondylar humerus fracture. Now, obviously, tell me which one will be more common. The posteriorly displaced supracondylar humerus fracture will be more common because the muscle pulls it posteriorly. So that is what you need to understand, that is displacement. Now, what do you mean by reduction? Reduction means bring the fracture fragment back to normal anatomy. Now, reductions can be many types: closed reduction, open reduction. We'll discuss that later. But bringing it back to normal anatomy is what is called as reduction. Now, the question is asked, how do you reduce a fracture? You have to apply a force. Now, this force that you use to reduce the fracture, let's call that a traction force. Let's call that the traction force. Now, this traction force has to be more than the displacing force. What was the displacing force? The muscle pull was the displacing force. So the traction force brings the, or helps us reduce the fracture. So displacement you have understood, reduction you have understood, traction force you have understood. Now, how the fracture will heal? The fracture will heal through the stages of fracture healing. For that, the fracture has to be brought back to normal anatomy and had to be kept there. So to keep the fracture fragment here in this reduced position, we will have to fix the fracture. This is known as fixation. Again, there are various types of fixations: internal fixation, external fixation, POP application. So many things are there. But you just need to understand the terms right now. So displacement, reduction with traction, and fixation at its original place. These are the terms that you should know. Right, so understood displacement, reduction, traction, and fixation. Okay, so now this is an X-ray of your elbow, lateral view. This is the humerus, this is the ulna, and this is the radius, and this is the condyles of the humerus. Just above the condyles of the humerus, there is a fracture, and the fragment is going posteriorly. This is a posteriorly displaced supracondylar humerus fracture. And so here is the explanation of what displacement, reduction, traction, and fixation means. Now, moving further, this reduction that we have achieved, now we have achieved the reduction by application of force, traction force, right? So there are three methods of reducing. There are three methods of applying the force to reduce. One is a manual reduction with the help of manual traction. Another is skin traction. Third is skeletal traction. Skeletal traction. Okay. So manual traction, skin traction, and skeletal traction. Manual traction is when you pull it manually yourself. Skin traction is when you apply a bandage and then pull the bandage through the force acting through the skin. And skeletal traction is when you put a pin into the bone and then pull the pins, pulling the pin and then pulling the bone with the help of the pin. That is skeletal traction. So manual traction, skin traction, and skeletal traction. Obviously, which will allow you to use more force? Skeletal traction will allow you to use more force. Skin traction more than this manual traction, right? More than the manual traction. So these are the various methods of traction. Now, whenever you apply traction, you have to also remember to apply counter traction. Because if you just apply the traction while pulling the fracture, you will pull the patient with you, essentially not reducing the fracture. So whenever you apply traction, someone else has to give counter traction so that the force acts on the fracture side to help you reduce the fracture. So suppose there is a fracture here. This gentleman over here is giving traction, and this gentleman over here is giving counter traction, and this is bringing the fracture fragment back to normal anatomy. If you just apply the traction without counter traction, the patient will be pulled. Okay. So once you have reduced the fracture by traction and counter traction, now you can decide what to do with it. In this case of close reduction and POP application, what you will do is you will reduce the fracture by closed method without opening the fracture site, and then you can apply the plaster of Paris. Let me show you a video so that you can understand it better.
Now in this video, I would like to show you the procedure of close reduction and POP application. For reference, this is a patient who has an extra-articular fracture of the upper limb, and we want to basically manage it by close reduction and POP application. Now, this is the forearm. As you can see in front of you, this is the forearm. And there are three people standing in front of you, and I'll tell you what their jobs are. This gentleman over here is basically applying the traction. He's pulling the distal part of the limb to distract the fracture so that the fracture can be reduced. And this gentleman over here, who's holding at the elbow, is the gentleman who's providing the counter traction. So there is traction being applied and counter traction being applied. So the forces that are acting on the fracture fragment to cause the displacement we're trying to neutralize those forces. And this gentleman right in the middle, he is waiting for the traction forces to act, and then he will manually reduce the fracture with his palms, and he will try to hold that reduction. And then we will slowly apply the cast padding, that is the cotton roll, and then we'll apply the plaster of Paris, and I'll show you how it is going. Traction is being applied, there is counter traction, and this gentleman in the middle is palpating for the fracture, and now he's trying to manually reduce the fracture. Now, once he's happy with the reduction that he's achieved, we will apply the cast padding or the soft roll or the cotton roll. As you see, this is the soft roll or the cast padding or the cotton roll that is applied. Basically, it helps absorb the sweat and the exudate and keeps the limb dry while we apply the plaster of Paris above it. This is the plaster of Paris. Calcium sulfate hemihydrate mixed with water becomes calcium sulfate dihydrate. Now we have placed it only on one particular part of the circumference. We have not covered it completely. So this is a slab or a splint. This is not a cast. Cast is circumferential. The reason we have not used a cast in this case is because this is an acute injury and there is chances that it will swell up because of the injury, and we do not want compartment syndrome. So we are only using a splint or a slab that is covering it in a part of the circumference that will allow for the swelling to happen, minimizing the risk of compartment syndrome. Obviously, the reduction will not be maintained very nicely with this, but that is not the idea here. That idea here is to just support the fracture for now. And later when the swelling comes down, we will convert this slab or splint to a cast completely by encircling the plaster of Paris all around the circumference of the limb. Now, once this slab is applied to a particular part of the circumference, we will keep it in place with the help of the gauze roll or the roller bandage. He's applying the roller bandage all around to keep the slab in place. And now he's molding the POP to the desired shape to keep the fracture in reduction. He will hold it for some time till the POP starts to heat up and set, and then the slab will be good to go. This is the procedure of close reduction and POP application. Obviously, you must understand now that the fracture reduction will not give you an ideal or perfect reduction because you have not observed the fracture under vision, but you will definitely use X-rays to confirm your reduction has been done or not. It will not be perfect, but you'll get the job done. Since it's an extra-articular fracture, we do not require perfect articular alignment. We can get away with, acceptable reduction. So this is close reduction and POP application.
Now that we have understood what is manual traction and how we reduce and we apply the POP, now I want you to understand what is skin traction. Skin traction is very simple. You apply a bandage on the skin and there are ropes attached to the bandage. You pull the ropes. The pulling of the ropes will cause force on the bandage. The bandage will pull the skin, will pull the soft tissue and then reduce the fracture. Next is skeletal traction. For that, you need to put a pin into the bone to apply traction to the bone. That is the skeletal traction. Now, what are the steps of skeletal traction and where do you put the pins into the bone? There are various places you can put the pin to the bone: distal femur, proximal femur, distal tibia, proximal tibia. The usual ones, the common ones are upper tibial pin traction or upper tibial skeletal traction. And this was asked on your exams, particularly the steps of skeletal traction. So what are the equipments you need here and what are the steps? How do you perform it? I will show you all of that. So this is a rough item list that you need. What do you need? You need a drill, obviously. You will need a drill. You will need a straight artery forceps. You will need 11 number blade, and you will need two types of pins that you can put in the bone: the Steinmann pin and the Denham pin. And you will use local anesthesia so that the patient does not feel pain. And this is the stirrup that you will use. This is known as Böhler stirrup. Böhler stirrup. This basically allows you to pull the pin. This is a stirrup that you will use. So these are the two types of pins: Denham's pin and Steinmann's pin, that you use to put in the bone. The Steinmann pin is a straight pin without any threading, whereas a Denham pin has threadings. Now let me show you the steps of performing a skeletal traction with the video.
Now in this video, I would like to demonstrate the upper tibial pin traction or skeletal traction that we apply to keep the fractures reduced. Now the instruments that we will use, I will show you step by step. This is the instrument. This is your Böhler's stirrup, or you call it the skeletal traction bow as well. Now these are the things that we need. This is the drill, and we have a local anesthetic. 2% lignocaine is fine, and we have 11 number scalpel blade, and we have the artery forceps. Now there are two pins that I would like to bring attention to you. Is number one, we have Steinmann pin, and we also have Denham pin. I'll show you the details now. Now Steinmann pin is a smooth pin, whereas a Denham pin is also a smooth pin, although in the center, right around here, you are seeing these threads. A Denham pin is basically used in osteoporotic bones, whereas Steinmann pin is used in stronger bones. Otherwise, Denham pin is usually also used for calcaneal tractions, and Steinmann pin is preferred for tibial or femoral tractions. Now I want to orient you to the video that I'm demonstrating here. This is the knee joint, nicely draped and prepared. This is the proximal part of the leg here. You can see the knee joint, and you can see this prominence over here. This is the tibial tubercle. What we are doing is, after preparing the site, we are localizing the location of insertion of the skeletal traction pin or the pin traction, which is ideally 2.5 centimeter below and behind the tibial tubercle. You can clearly see that this is the tibial tubercle, and the needle is being marked just 2.5 centimeter below and behind the tibial tubercle. I'm trying to inject the local anesthetic here all the way in the skin, the subcutaneous tissue till the bone. And this is the lateral side of the leg, and this is the medial side of the leg. We always enter through the lateral side of the tibia and then go out or exit from the medial side. You can see the tibial tubercle being demonstrated, marked 2.5 centimeter below and behind, and local anesthetic is being injected from the skin, subcutaneous tissue all the way up to the bone. This is the entry site. We do not want the patient to be in pain. And we are also doing the same for the exit side, where we are inserting the local and where we are injecting the local anesthetic on the exiting site. Now, once we have marked the site for insertion, we are using an 11 number scalpel to make a puncture or a stab wound from the skin, soft tissue up to the bone, so that the skin is not burnt or there is friction while we are passing the Steinmann pin. Or sometimes, if the Steinmann pin or the trocar of the tip is sharp enough, we directly go ahead and drill the tibia with the drill itself. So the stab incision is being made here. Now you can see that we are using an artery forceps here to dilate the entry site or the entry wound, so that we can access the bone and make sure there is no soft tissue in the path of the pin. So we are dilating and clearing and making sure that there is no soft tissue on the way. Now this is the Denham pin that we are showing you here, clear pin, and you have the central part which is threaded. This obviously, because the bone is osteoporotic, must be an elderly female on which we are using this. Now it is mounted over the drill and the pin is placed on the bone. Again, reconfirm that it is just 2.5 centimeter below and behind the tibial tuberosity. Now attached to the drill, and in full speed, we are drilling all the way from the lateral to the medial side, perforating the bone, the soft tissue, the fascia, and the pin comes out on the medial side through the skin. You can clearly see that it is coming out here. And we'll make another stab incision just to help the pin come out easily without damaging a lot of soft tissue and skin. And it has successfully come out So it has come out on the medial side now. Now we'll remove the drill and apply dressing here so that the entry site and the exit site does not get infected, because the most common infection for pin tract sites is infection by organisms Staphylococcus aureus, and we do not want that. And also remember, following the application of these pin tracts, you can get a pin tract sequestrum, which is a ring-shaped sequestrum around the entry and the exit site of these pins. In order to prevent that, we are covering it nicely with this betadine-soaked gauzes. Now we are using the Böhler stirrup that I have shown you in the images and mounting it over this Denham pin nicely, making sure it is equal on both the sides. Now we'll lock the stirrup to the pin, and you can clearly see that this Böhler stirrup would be free over the Denham pin. Clearly see that it is free and still mounted on the pin. Now this ring that you see over the stirrup at the end of the stirrup is the ring where we tie our skeletal traction rope. Towards the end of that rope, we have our weights, can be somewhere around 10 kgs, 15 kgs or 20 kgs. That will help us keep the fracture reduced for lower limb fractures. So this is your upper tibial pin traction, and these are the steps that we perform and make sure that the wound is neat and clean, because at the end of the day, it's an invasive procedure where you're putting a foreign object through the bone of the patient. It can be used for majority of the fractures in the lower limb, particularly your intertrochanteric fracture, your femur fracture, your distal femur fracture, and it helps the fracture to be kept in reduction. And you can now mount this patient either on the Böhler and Brown splint or the Thomas splint or any other kind of splint of your choice.
Now, once the fracture is reduced, either by skeletal traction or skin traction, you can temporarily stabilize the fracture on a splint. Right? This is a splint device that allows for the traction and supports it with a splint. So there are two important splints that you should remember. These are Thomas splint and Böhler and Brown splint. A lot of MCQs are asked around this, although this is a temporary modality, but you should nevertheless know them. So a Thomas splint was invented by Dr. H.O. Thomas over here, which was originally invented by him for his wife who had tuberculosis of the knee. That is also an old MCQ. It is a fixed traction device. What is a fixed traction device? It's a traction device that has both traction and counter traction in itself. So what you do is you basically put this device on the lower limb, the ring going and sitting on the perineum, and the lower limb all the way in the Thomas splint. Now, whether you apply the skin traction or skeletal traction, you pull it and tie it to the Thomas splint. So the ring goes and you pull the limb. So traction and counter traction are acting on one individual device. This is a fixed traction system. The beauty of a fixed traction device is that it allows for mobility of the patient, meaning you can move the patient wherever you want to in the fracture that is reduced in position. So this was used usually in the wartime, particularly for lower limb fractures like femur fracture. Once you've applied this Thomas splint for a femur fracture, the fracture would be reduced and the device is a fixed traction device. So you can move the patient wherever you want without worrying about the fracture moving. Now, the dimensions of the rings and what is the length of the Thomas splint that you should use, all of these are mentioned here, but most of the times they're not asked on your MCQ exam. So if you're preparing for a professional exam, you can pause the video over here and take down the points that you need. But MCQ, I've not seen a lot of questions except where it is used for. It is used for lower limb fractures, particularly femur fracture, and it's a fixed traction device. On the other hand, Böhler and Brown splint is a sliding traction device. Sliding traction device is when you apply the traction, either a skin or a skeletal traction, and put the patient on the splint. The traction is achieved by the pull, but the counter traction is not within the device. It is acting based on the sliding or the gravity. So what you have to do is you have to mount the patient on this splint and you have to tilt the bed so that the leg side of the bed is at a higher level compared to the head side. So the bed is tilted, and once the bed is tilted, the patient will start sliding. That sliding force or the gravity force acting on the patient act as a counter traction against the pull of the weight as a traction device. So the pull is by the weight, that is a traction, and sliding of the patient is the counter traction device. So this is a Böhler and Brown splint, again used for lower limb fractures, femur or tibia fractures. Okay, so here you can see clearly that we have raised the leg end of the bed with these bricks. So what happens now? The patient is sliding towards the head end. So that is the counter traction. A Böhler and Brown splint is usually used in wards because it is not a fixed traction device. It is a sliding traction device. You need the position of the patient to act as a proper counter traction device. Okay. So this is a Böhler and Brown splint. An important MCQ here is that there are three important pulleys here. This is pulley 1, this is pulley 2, and this is pulley 3. So pulley 1 is usually used when you're trying to reduce tibia fractures. Pulley 2 is usually used if you're trying to reduce the femur fracture, and pulley 3 is usually used if you're trying to prevent the foot drop in a patient who has foot drop. Okay, so those are the questions that are asked. Another important traction that is asked on your exam is Russell's traction. Russell's traction is used for intertrochanteric fractures of the femur.